So we're now going to move on to the next section of this training session and discuss male infertility. My remit is to talk about the workup and the investigation of a patient with infertility, and Asif Munir will follow on then to talk about the surgical treatment. So here we go. So normal fertility, as you well know, relies on healthy spermatogenesis, maturation of sperm within the epididymis, successful intercourse, and those topics there in red are really the remit of the male doctor, the andrologist or the urologist, and the rest of the pathway there, generally the domain of gynecologists. Male fertility or male infertility contributes in total to around half of all infertility cases, around 25% solely male factor, and a further 25% or so in combination with female problems. And we don't always find an underlying cause. In approximately 40%, there is no clear identified cause for the male factor problems. When I think of male infertility, I tend to think about categorizing it into three sections. I'd like to think of, because basically this has an impact on how you're going to manage the patients. So you don't think of them having mild derangements in semen analysis, anything less than 15 million per mil, or men with very severe male factor infertility with very low numbers of sperm, changes in the appearance and in the motility of sperm, the so-called OATs or oligoacinoteratozoospermia. And these men invariably will end up requiring ICSI IVF, whereas the oligos may respond to lifestyle factors, varicocele treatments, etc. And then thirdly, azoospermics, and that's a distinct category in itself that we're going to concentrate a little bit more on today, because actually that is really for a urologist, that is where we really do get involved, is in the azoospermics. I also like to remind myself, particularly when looking at the semen analysis, that this is a quite an old graph now, but it shows the same man producing a sperm count twice a week for 2 years, and in itself that was a feat. But just to highlight that the sperm concentration or the sperm count varies so much over that 2 years, drifting in and out of the normal range, and right down there and 2/3 of the way along to a very low level. Clearly there's something going on there, either an intercurrent illness or some factor or other. And the point to highlight here is that essentially there's no point in looking at a single sperm count alone. You really need to look at 2 or 3 analyses over a period of time before building up a picture of whether or not there really is a problem. And the first thing to say to any man with a single abnormal sperm count, particularly if it's just below the normal range, is to reassure them that this could be a blip. It could be that it is better or can be improved upon. So moving on to the clinical evaluation, I think I've intimated already that the key thing for these men is to see a urologist or an andrologist or a uroandrologist, whatever you want to call them, but essentially not for them to be in with their female partners, seeing a gynecologist who is focusing entirely on the female. And that does happen a lot. It happens a lot in the UK for certain, and it happens worldwide. And therefore, as an infertile or a subfertile man, really what you need is to go and see somebody who's taking an interest and has expertise in getting to the bottom of things and doing a full evaluation. So these men all need a full history and clinical examination, that goes without saying. And then selectively, after that, they will require hormonal analysis, genetic tests, and potentially some radiology, depending on what the problem is. And we'll go on and talk about that in a second. In terms of the history, then clearly we're going to start off by asking, have there been any testicular problems in the past? In particular, have they had surgery as a child, orchidopexy, hernia surgery, torsion, trauma to the testes, or indeed any congenital problems. Secondly, are there any sexual or ejaculatory symptoms or difficulties? Is there any history of endocrine disorders, particularly growth development issues? Have they had any hormone therapy in the past? And moving on, linked to that, their medication history. There are certain drugs, sulfasalazine, famously one of them, anabolic steroids, testosterone, obviously chemotherapy and recreational drugs that will have a major impact. And we are seeing increasing numbers of men who've been taking supplements or steroids or testosterone down the gym unprescribed, who maybe did not realize initially that this has a negative impact on their testicular function, on their sperm production. Next, we need to ask about infections. Have they had any GUM infections, any sexually transmitted diseases, any discharges, anything that could potentially cause adhesions within the ejaculatory system? And has there been any orchitis, particularly mumps orchitis, particularly bilateral mumps orchitis, because that can certainly damage sperm production. Then we need to go on and discuss lifestyle, what levels of physical activity. There are associations between certainly smoking, but also associations between body mass index, the metabolic syndrome, levels of physical activity with sperm count. So this is particularly useful in the oligozoospermic cohort. And then finally, their alcohol intake. And whilst moderate alcohol intake is okay, clearly heavy alcohol intake can have an impact. And finally, are there any familial problems? Is there any cystic fibrosis or any other genetic problems or syndromes within the family? So there's a lot there to get through. Then we go on and examine them. This is critical again, and it still amazes me how many men eventually come to the male fertility clinic, having been trying for years, maybe having had a few rounds of IVF, and actually nobody has examined them at all during that period. It's very important to look for secondary sexual characteristics, any signs of endocrine disease. Critical, obviously, to look for the presence of a varicocele, and we'll go on and discuss the impact of varicoceles later on. We need to look at testicular volume, testicular size and consistency. Are they normal? Are they small? Can you feel them at all? Are they in the right place? And then onto the epididymis. Is it palpable or not? If it's palpable, is it distended? Is it firm? Has it got cysts within it? And linked to that, can you feel the vas deferens? And we can have unilateral or bilateral absence of the vas deferens. We can have segmental loss of the vas deferens or epididymis. So it's very important to identify all the structures in a very basic way, and finally not forgetting to perform a digital rectal examination. Some people use the orchiometer, but essentially you're looking for a testicular volume, or testicular length, I should say, of around 3.5 to 4 centimeters as being roughly normal. If you look at the two, anything below 2 centimeters is very unlikely to be making normal volumes of sperm. And that just shows us the anatomy that we are trying to identify whilst examining the patient. In terms of assessment, so we've taken a history, we've examined, and then of course further assessments really depends on what the semen analysis shows. The semen analysis is obviously the cornerstone of male fertility assessment, and the sooner they have one of those, the better. Important facts to note here are: don't rely on one specimen, like I've said. Make sure it's not produced within, make sure that they've had a period of abstinence, of around 2 or 3 days, but no longer than a week. And then sample needs to be delivered fresh to the lab. And the best services, I would say, have a facility where the specimen can be produced on site, and then it can be analyzed straight away. And then depending on what the semen analysis shows, we may then need to go on and think about further investigations. And certainly for those with severe male factor infertility, those with OATS and those with azoospermia, they all need further tests. We need to look at the FSH in particular. Follicle stimulating hormone drives sperm production in the testes, and therefore needs to be in the normal range. If the FSH is low, then that will drive less sperm production, and if it's very high, then it indicates that there is a problem with sperm production down in the testes, and that then tends to direct us towards a potential diagnosis of testicular failure. Now, the World Health Organization has published several updates on the reference ranges. The current reference range specifies that we need a 1.5 mils semen volume. We need a concentration of 15 million per ml. And progressive motility needs to be 32% of sperm or more. And then the morphology at the bottom there, we need 4% normal forms, which sounds like a very small number, but actually, obviously the concentrations and the total number of sperm is very high. So even 4% is still a large number of sperm. And it essentially describes how many of them are fully matured and have all the right bits and are moving, or beg your pardon, who appear completely normal. So we do need 4% normal forms. In terms of radiology, not all patients will need radiological investigations, but clearly if we're suspecting a varicocele, then it is useful to get an ultrasound scan done. It can sometimes detect contralateral varicocele as well. It can give you a more accurate description of testicular volume, and in particular we know that men with male infertility problems have other associated problems such as increased risk of malignancy, and therefore it is a good screen to detect any other problems going on. In selected patients, those in whom you may suspect an obstruction of the prostate or the ejaculatory duct level, and we'll go on to discuss that in a second, then transrectal ultrasound scan of the ejaculatory apparatus is a very good test. Alternatively, MRI scan. Then even less frequently required, but if you're suspecting an obstructive component within the epididymis or within the scrotal or vas in the groin, perhaps after groin surgery or whatever, then vasography can sometimes be of help, but isn't very frequently used. And venography, again, used as a prelim to embolization of varicoceles or in difficult diagnostic cases. Another investigation that is sometimes used, certainly not routinely, but it is available and can sometimes help, and that is the DNA fragmentation index. This tells us what percentage of sperm have fragmented DNA, and less than 15% generally equates to reasonably good fertility potential, whereas over 25% reduced fertility potential. And the relevance of this mostly really is in association with varicoceles, which increases the DFI, and there are some papers describing improvements in DFI with varicocele treatments. So I mentioned that we were going to focus in on azoospermia because this is really what urologists get involved in, and my way of classifying this, and the standard way of classifying this, is either into obstruction or testicular failure. And you really do need, it's very important to distinguish, or try and distinguish before you do anything further, as to whether this is an obstructive problem or not. Obstruction can be at any level, from the ejaculatory duct all the way down into the testicle, and then testicular failure can be due to any reason that may have damaged the testes. As we mentioned earlier, it is not always clear. In about 60%, we don't find a distinct cause, so-called idiopathic, but in the others, maldescent, infection, mumps, in particular, torsion, trauma, chemotherapy, radiotherapy, Klinefelter's genetic problems, Y microdeletions, can account for the testicular failure. When we examine them and trying to distinguish which, is this man in front of you who's got azoospermia, have they got an obstruction or have they not? Then we need to look at the FSH level. As I said, if the FSH is raised, then that's pointing towards testicular failure, and that would fit with smaller volume testes, but that is not always the case, in which case these men are going to have to go on and have an in-depth surgical sperm retrieval, or so-called microdissection, TZ. If you feel that the testes are normal, you might be able to feel a distended epididymis. You might feel there's no vas, and the FSH is normal, and it all fits in with a history. There may well be, in that case, an obstructive element, in which case these men are more suited to aspiration of sperm from the epididymis, so-called PISA, or percutaneous epididymal sperm aspiration. So if you think they're obstructed, then we need to look at the semen volume to start with. Low volume azoospermia, less than 1 mil, with a low pH, is suggestive of a problem at the prostate level, and we are therefore thinking whether or not there may be ejaculatory duct obstruction. We don't really use fructose concentration routinely anymore, but that would be low in these men if it were investigated. So the causes of low volume azoospermia may be congenital absence of the vas deferens, where the seminal vesicles have also become atrophic, or bilateral ejaculatory duct obstruction. And of course, it's key in obstructed patients to feel for the vas deferens, and if you can't feel it, then it's probably not there. They're fairly unmistakable, thick structures, obviously within the spermatic cord. And it's important then in obstructed patients that you recognize that in most of these men, 95% plus of them, that the spermatogenesis within the testicle is going to be normal, and their odds of finding sperm on a sperm retrieval are going to be very, very high. TRUS, as I say, transrectal ultrasound, is very good at looking at the ejaculatory ducts. And you can see there on the picture on the right, a dilated ejaculatory duct running through the prostate. Vasography, that's just a slide showing how vasography is done. Not very often done these days, but in selected specialized cases, and is always done at the time of scrotal exploration. You can't do a vasogram in the outpatients transcutaneously or percutaneously. You've got to do it really by delivering the testis and the vas in order to get that needle into the lumen. Now, more common is testicular failure. So by far the commonest reason for azoospermia is failure of production. And this will often be accompanied by a reduced or small testes, a raised FSH, sometimes genetic problems, and ultimately will need a microdissection TZ. Question is, who should have, overall, for the infertile population, who should have genetic analysis? The azoospermics, very definitely. And men with severe oligozoospermia, the EA guidelines suggest anything less than 5 million. Cryptozoospermia, where there are very, very few sperm present and only present on centrifugation. And then there's more debate as to whether there's a role for genetic analysis in subsequent miscarriage problems. In terms of detecting genetic abnormalities, there are essentially 3 genetic tests that we use for infertile men. They are there in that box on the bottom. First thing is the karyotype, the XY makeup. Secondly, deletions within the Y chromosome, or so-called Y microdeletions. And then in selected patients, again, when you cannot feel the vas deferens, and there is a possibility on a clinical basis that there is congenital bilateral absence of the vas deferens, then the cystic fibrosis gene point mutations. So first of all, the commonest genetic abnormality of Klinefelter syndrome. So we do a karyotype. There's the normal karyotype at the top, 46XY, and then on the left there, Klinefelter's 47XXY with an extra X. On the right, The SRY syndrome, the double X male syndrome, much rarer, and then isodendritic or an abnormal Y chromosome at the bottom there, again very rare, and by far the commonest karyotype number abnormality is the Klinefelter syndrome. They don't all fit this phenotype. In fact, this is a bit of a stereotype phenotype, but it's essentially they certainly don't all come across like this and can present quite late, and there's very definitely a high incidence of diagnosing Klinefelters within the fertility clinic, very often for men in their 30s. It's, as I say, the commonest chromosomal abnormality. It can be in mosaic form as well, but essentially it's 47XXY. If it is diagnosed early, then there is a case for going in and retrieving sperm at an earlier age. They may be hypogonadal biochemically, they may have a low testosterone, and there may be a case for wanting to correct that. And if there is one key message from this talk today, and that is that you cannot give testosterone therapy to any subfertile men who haven't completed their family or made some provisions, because testosterone therapy will completely suppress sperm production and make chances of success much lower. Therefore, do not give testosterone to young men who haven't had their family yet, unless, of course, sperm has been stored or there are circumstances where it's been deemed okay to proceed. And as I said, these men will end up requiring microdissection, TZ, and the sperm retrieval rate may surprise some, but there are reports of up to 50% or more success rates in terms of finding sperm in Klinefelter's patients. Next one, Y microdeletion. So there is a zone on the Y chromosome, the so-called AZF region of the Q arm, azoospermia factor, divided into A, B, and C. The abnormalities or deletions of the AZF region can be found in up to 12% of men. And as I said earlier on, the EAU guidelines suggest that anybody with a count of less than 5 million undergoes this test. The question is, why do we bother testing for this? There's nothing we can do about it, but it does, as our next slide will tell you, affect the prognosis or the likelihood of success from surgical sperm retrieval, but also it allows us to perform genetic counseling. And if there is a Y microdeletion, then it is important to tell the man that any male offspring will also carry the Y microdeletion. Y microdeletions vary in incidence across the world, highest in North America, then Africa and Asia, and slightly lower in Europe, but generally a range between 6 and 8% of infertile men. There are various phenotypes depending on whether A, B, or C is deleted, and in summary, C is the good one. AZFA usually translates to Sertoli cell-only syndrome and azoospermia. A complete deletion of AZFB will lead to maturation arrest, again with no prospect of harvesting mature sperm. If there is a partial deletion of AZFB, there may be sperm. And then in the AZFC group, there is a good chance of harvesting sperm. And fortunately, the commonest abnormality by far is the AZFC deletion, accounting for nearly 80% of AZF Y microdeletions. And as I said, AZFA is likely to be leading to azoospermia, whereas AZFC may even have sperm in the ejaculate or have a fairly high chance of retrieving sperm on surgical sperm retrieval. Finally, the point mutations, we described the cystic fibrosis gene mutation. Approximately 4% of Caucasians carry the CFTR gene, and it is associated with congenital bilateral absence of the vas deferens and therefore obstructive azoospermia, and this carries a very good prognosis, therefore, in terms of harvesting sperm. The key things with the cystic fibrosis gene carrier group is that the partner is also screened, because if she is a carrier, then obviously there is a chance of offspring being fully affected with cystic fibrosis. Because it's an obstruction, then a PISA or a random biopsy would usually suffice, and pre-implantation genetic diagnosis is possible for these couples. So I'll finish there. Thank you.